Good morning, everybody. Today we are going to talk about oral submucous fibrosis, which is a premalignant condition. Before we get into what is oral submucous fibrosis, let's talk about what is premalignant condition. Premalignant condition is a generalized state associated with significantly increased risk of cancer. It's a generalized state of the body, unlike a premalignant lesion, which is a localized, morphologically altered tissue. The few examples of premalignant conditions are oral submucous fibrosis, actinic keratosis, erosive lichen planus, discoid lupus erythematosus, disc keratosis congenita, epidermolysis bullosa, Plummer-Vinson syndrome. And the most important here is oral submucous fibrosis. So, for any student, the most challenging part while studying oral submucous fibrosis is to remember the big definition. Okay, so to remember the definition, I have given this picture. So all of us have different stages of life, right? First, we have this stage where we are very happy playing as a child, as a childhood. Okay, then we will be associated with somebody throughout our life, followed by a loss of one person, okay, and leading to the loss of both the persons in the life. So this is how life is, right? So the life is preceded by a very single happy childhood, followed by a person who's associated with you, maybe a male or a female partner. And then one day we'll have to lose one of them, and one person will have to live single. And then this is followed, leading to even the other person is lost. So here, this picture is not for any moral values here. This picture is for you to remember these 4 words: preceded, associated, followed, and leading. Okay, preceded, associated, followed, and leading. So when you remember these 4 words, you can remember the definition of OSMF. So this definition was given by Schwartz. He defined OSMF as atrophica idiopathica mucosa oris. This was the name given for OSMF by Schwartz. Later, Sirsat and Pinborg gave this the most challenging definition. Okay, the definition is, it's an insidious chronic disease. It's an insidious chronic disease. It's a chronic disease. It affects any part of the oral cavity. It affects any part of the oral cavity. And sometimes it affects the pharynx. So occasionally, now comes our terminology. Occasionally, it is preceded by or it is associated with vesicle formation. So occasionally it's preceded by, before the lesion has occurred in the oral cavity, we will be having vesicles formation. And this is always associated with juxtaepithelial inflammatory reaction. That is, just below the epithelium, you will have inflammatory reaction. A lot of inflammatory cells come into play just below the retiprocesses, just below the basement membrane. You will have a lot of inflammatory process, juxtaepithelial inflammatory reaction, but this is always present, so associated. So preceded by vesicle formation, associated with juxtaepithelial inflammatory reaction. Now go to the third word, that is the followed by hyalinization of the lamina propria. I told you, just below the epithelium, you will have inflammatory cells coming into play, and this is now followed by, just below the epithelium, you will have hyalinization, followed by hyalinization of the lamina propria. When all these fibrosis is happening under the epithelium, now the basement membrane or the retiprocesses, which was having a wavy course, because of so much of fibrosis that is happening in the connective tissue, the retiprocesses which were in the wavy projections now is turned into flattened retiprocesses. So now you have followed by hyalinization of the lamina propria, and because of flattening of the retiprocesses, you also have a reduction in the epithelial cells. So this is called epithelial atrophy. So you have epithelial atrophy leading to stiffness of the oral mucosa. This will lead to stiffening of the oral mucosa. and progressive limitation in mouth opening, because of which there is progressive limitation in mouth opening. So the terminologies you have to remember is preceded, associated, followed, and leading. So it's preceded by vesicle formation, associated with juxtaepithelial inflammatory reaction, followed by hyalinization of lamina propria with epithelial atrophy, leading to stiffness of the oral mucosa and progressive limitation in mouth opening. So imagine when there is so much of fibrosis happening in the connective tissue, then what will happen? The muscles also get fibrosed and movement of the oral cavity is very difficult. So the muscles do not function. So then there is a limitation of mouth opening. The person will not be able to open his mouth. This is the definition. So this is the definition given by Sirsat and Pinborg. So any essay question, you will start with the definition given by Sirsat and Pinborg. Next is the epidemiology. This affects up to 0.5% of Indian population, and the incidence is rising, especially among youngster populations. And the most common etiology of OSMF is areca chewing, and also few articles have cited the importance of capsaicin in the etiology of OSMF. Capsaicin is a component that is present in red chilies. Okay, so people who consume a lot of these red chilies also, and we're not consuming arecanut, we're also getting OSMF. So they understood that the component called capsaicin present in red chili also is responsible for causing OSMF. And they also found that iron deficiency and vitamin B12 deficiency also affects the integrity of oral epithelium. And because there is the epithelial integrity is lost, this will allow the absorption of arecanut into the mucosa. So iron deficiency or vitamin B12 deficiency facilitates the absorption of arecanut alkaloids, which could be the cause of OSMF. And they've also understood that there can be genetic susceptibility like HLA, A10, B7, DR3, transforming growth factor beta. All these could also be associated with OSM. So to remember the etiology, the most common etiological factor is arecanut, which is nothing but the arecanut is a product which is consumed in different forms. Okay, so arecanut is the most important cause, and the other cause could be red chilies. And then, of course, vitamin B12 deficiency, which causes a loss of the epithelial integrity, also could be one of the cause, and genetic susceptibility also could be one of the cause. Now, let me talk in detail about arecanut. So, it's an endosperm, okay, of the fruit Areca catechu. And this is it's like a palm tree, and there you have these arecanut grown. And it's consumed as a traditional practice in the South Indian population. Okay, so different form of consumption of arecanut is either you can use it as a betel quid, which is the most common way of consuming, in the traditional way of consuming it. One, you take this betel leaf and they add slaked lime, and they add these arecanut in the form of granules, or it can be just chopped arecanut. They add to it because it's very hard. Okay, so you can get it as flakes, and or this entire thing has been soaked and then cut down. So it's used in here. Along with this, they also take some tobacco products like tobacco leaf is consumed, raw tobacco leaf is consumed. So this is how a betel quid is made. So you have a betel leaf. Along with it, they consume slaked lime. So they add these arecanut granules, and they also add tobacco to it. So this forms a betel quid. Now this is now folded, and they consume it. This is called betel quid. So it's the most common practice in South Indian population. So the first thing is betel quid, and also sometimes arecanut is just consumed in a raw form. So in the form of sebal flakes, that is just you have grated arecanut. So it's called sebal flakes, or they consume it in the form of kotapaka, which is the entire arecanut, the whole seed is soaked properly in water, and then they they consume it, or they just powder it in the form of a granule. It's called Kotapaku granules. Or it can be consumed with various additives agents, like pan masala, which is called pan masala, where they add other additive agents like tobacco and flavoring agents, which will also cause a lot of addiction. And it can also be consumed in the form of gutka, which is a powdered arecanut plus tobacco. So to sum up the components of arecanut, if you take arecanut, there are three components. One is flavonoids, the other one is alkaloids, and we have others. So alkaloids are arecolin, arikidin, guasin, isoguasin, aricoladin, guacolin. So if you take flavonoids, you have tannin, gallotannic acid, and catechol. And others, you have fat, carbohydrates, protein, and few mineral matter. So if you take arecanut, the composition of the components of arecanut is alkaloids, flavonoids, and others. So alkaloids, you have arecolin, arikidin, guasin, isoguasin, aricoladin, and guacolin. So let's get into the pathogenesis. Now we know the components of the arecanut and all those things. Let's get into the pathogenesis. So simply what is happening in OSMF is there is an increased collagen production. So if you imagine the connective tissue, which was actually made up of loose collagen fibers and which is supposed to be having a lot of blood vessels, now is being transformed to a fibrosed mass where the collagen fibers have increased in number and compress the vasculature. So there is less amount of vasculature there. And also, what are the other components of connective tissue, like, salivary gland duct and other structures also having got compressed now. So there's the first thing that is happening here is increased collagen production. So this increased collagen production is being favored by the component called aricolin. And the second thing that can happen in OSMF is decreased collagen degradation. So the collagen is not getting degraded. So this is done with the help of tannins. And the third thing that's happening is collagen stabilization. So the three things that's happening in OSMF is either there is a increased collagen production, or there can be a decreased collagen degradation, or could be a increased collagen stabilization. So increased collagen production is by aricolin, decreased collagen degradation is by tannins, and the collagen stabilization is by copper. So whatever it can be either increased collagen production or it can be decreased collagen degradation. All these will cause increased collagen production. The copper actually, what it does is it will help in getting clumping of all these collagen fibers. It stabilizes the linkage between the collagen fiber, increases the cross-linking of collagen fibers. Now, ultimately, whatever is happening, there is increased collagen production, or there's going to be increased collagen cross-linking, whatever is going to happen. This all is going to end up in a severe fibrosis, so much of fibrosis, okay? So collagen fibers all accumulates and now there is going to be increased fibrosis. Okay, let's look into the different pathogenesis, okay? So increased collagen production is favored with the help of alkaloids, transforming growth factor beta. Decreased collagen degradation is favored by tannins, which inhibit collagenase, an enzyme which is responsible for the breakdown of collagen. But when the collagenase enzyme has been inhibited, doesn't break down collagen, so there is going to be increased accumulation of collagen. And here also, it's like a double-edged sword. No? Transforming growth factor beta is also increasing collagen production. Also, it helps in decrease collagen degradation. Both the way it acts. Okay. And so this transforming growth factor, how it decreases collagen degradation is by activation of the plasminogen activator inhibitor. So it activates the plasminogen activator inhibitor, or it also activates the tissue inhibitor of matrix metalloprotease, TIM. So you just remember these two words. One is activation of the plasminogen activator inhibitor or activation of the tissue inhibitor of matrix metalloprotease. So these two ways, the transforming growth factor beta is actually reducing the collagen, decreases the collagen degradation. So how is transforming growth factor beta come into play? We have seen that there is a subepithelial inflammatory reaction. So all this inflammatory processes will lead to increase in transforming growth factor beta accumulation. And also copper, which actually is present in the saliva, okay, it diffuses into the connective tissue through the epithelial cells, it reaches the connective tissue, and it increases the lysyl oxidase. It activates the enzyme called as lysyl oxidase. And this lysyl oxidase causes increase in cross-linking of the collagen fibers, which will lead to fibrosis. So copper increases the lysyl oxidase, which will increase fibrosis. So basically, ultimately you have extensive fibrosis happening because of increased collagen production, which is favored by alkaloids and transforming growth factor beta. Decreased collagen degradation, which is favored by tannins and transforming growth factor beta. The transforming growth factor beta activates the plasminogen activator inhibitor, or it can activate the tissue inhibitor of matrix metalloprotease, or that could be increased cross-linking, which is favored by copper, which actually activates the lysyl oxidase enzyme. This flowchart tells it all. So here you have transforming growth factor beta, which increases the collagen production and decreases the collagen degradation. How it increases the collagen production is transforming growth factor beta activates the pro-collagen gene. It activates the pro-collagen gene. So when a pro-collagen gene is activated, that means there is going to be, the gene is going to give rise to its component protein, which is going to increase in number. So the pro-collagen protein is increased. So when the pro-collagen is a precursor collagen that is going to be increase in collagen production, and so there is ultimately increase in fibrosis that is happening because of the increased collagen production. So this is first pathway. That the second pathway is how transforming growth factor beta reduces the collagen degradation. First thing is by the tissue inhibitor of matrix metalloproteinase gene activation. When it's activated, so obviously whenever a gene is activated, the component protein is going to get increased. So you have an increase in the tissue inhibitor of matrix metalloproteinase. Now, when this is increased, this inhibits the collagenase. Collagenase is an enzyme which is responsible for breakdown of collagen. Now, this collagenase is being inhibited, and because of which there is a decrease in the collagenase activity and there is decrease in collagen degradation. Now, let's go to this pathway. When there is an activation of the plasminogen activator inhibitor gene. Okay, so there is this increase in the plasminogen activator inhibitor. So whenever a gene is activated, the component protein is going to increase. So we have an increase in plasminogen activator inhibitor. So the conversion of plasminogen to plasmin is not happening. So when there is an increase in the plasminogen activator inhibitor, there is a conversion of plasminogen to plasmin doesn't take place. So the conversion, the plasmin is responsible in general. If you see, if at all the plasminogen is converted to plasmin, the plasmin is responsible for conversion of the pro-collagenase to collagenase. Now you have an increase in collagenase, there is going to be increase in collagen degradation. But this pathway is totally being obstructed because of the increase in plasminogen activator inhibitor. Now the plasminogen is not getting activated to get converted to plasmin. So there's an ultimate failure. Okay, there's an ultimate failure in the conversion of pro-collagenase to collagenase, because of which there is again same decrease in collagenase activity and there is decreased collagen degradation. So this transforming growth factors beta's activity should be understood in two forms. One is how it increases the collagen production and how it decreases the collagen degradation. So now when you talk about all these things, you know that there is so much of fibrosis that is happening ultimately. And all the connective tissue structures now undergo extensive fibrosis, because of which the collagen, there is stiffening of the oral mucosa, and because of which there is reduced mouth opening. To understand this concept, first you should know what is a normal mouth opening. So how is the mouth opening measured between the incisors? If you keep a scale, or if you can use your divider and place it between the tip of the incisors, and then you will know the measurement of the mouth opening. So for male, it is about 47.5 and female, it is 44.6. And if you take the tongue protrusion, if you keep a scale below the tongue, after it has been protruded maximum, from the tip of the lower incisor to the tip of the tongue gives you the tongue protrusion measurement, which is about 24.9 in male and about 24.8 in female. And you can also measure the cheek flexibility. So you can ask a patient to blow. So the cheek blowing capacity is measured, and it could be 9.7 mm in male, and female it is 9 mm. So let's look into the clinical features. If you take, it's more common in male. So male is to female ratio is 4:1. And if you look, it has a wider age group from young adults to older age group. And the site is buccal mucosa, retromolar region, soft palate, uvula, bilabial mucosa, floor of the mouth. So again, site is like any intraoral site can get affected. And the patient's major complaint will be he will be having difficulty in mouth opening. Other than that, the patient will also have severe burning sensation, because the salivary ducts have been compromised here, because it has been compressed here. The flow of saliva is reduced, because of which the patient's taste sensation is altered. And also the patients will not be able to, will have burning sensation. Not only that, there will be severe pallor of the mucosa. This is also related to extensive fibrosis. When there is an extensive fibrosis, the blood vessels are now compressed and it's compromised. The vascularity is compromised here, because of which the mucosa appears very pale. This causes pallor of the mucosa. And when you touch and palpate the buccal mucosa, you will be able to feel palpable vertical bands because of the extensive fibrosis. These are called fibrous vertical bands, which can be felt on palpation. This is a very important feature of OSMF. And if you look into the initial stages, we saw in the definitions preceded by vesicle formation. So initial stages, you have vesicle formation, and you can have petechiae, melanosis, and xerostomia, which is decreased salivary flow. So let me talk about the grouping of the patients given by Dr. Ranganathan et al. Dr. Ranganathan et al. has studied multiple patients, and he has given a classification or grouping of the OSMF patients. So he's grouped, the first group 1 is only symptoms without restriction in mouth opening. Without any restriction in mouth opening, if the patient is only having symptoms, then it is called group 1. If the patient is going to have limited mouth opening, and which is but above 20 mm, okay, if the measurement is above 20 mm, then they are grouped under group 2. If the mouth opening is below 20 mm, they come into group 3. And group 4 is OSMF with precancerous lesion or cancerous changes throughout the mucosa. If the patient is going to have precancerous lesion or cancerous changes throughout the mucosa, they will be grouped under group 4. So we have group 1, group 2, group 3, group 4. Group 1 is only symptoms without restriction of mouth opening. Group 2 is limited mouth opening above 20 mm. Group 3 is below 20 mm. Group 4 is OSMF with precancerous changes. And there is one more person who has done a lot of studies in OSMF. It's Dr. Rajendran et al. In 2003, he had given, based upon the symptoms, he's given a grouping for the patients. So as early OSF and late OSF. So the early OSF features are burning sensations, vesicles, especially on the palate, dryness, and defective gustatory sensation. These are the features of the early OSF: burning sensation, vesicle formation, dryness of the oral mucosa, and defective gustatory sensation means they will not be able to experience the taste properly. The advanced OSF features are Now, it is all the features that are related to extensive fibrosis. The first thing is blanched oral mucosa, which is associated with a decrease in vasculature in the oral cavity. So there is a blanching of the oral mucosa. When you actually look in the oral cavity, it's more pale. And there is extensive fibrous banding, which can be palpated on the buccal mucosa and the labial mucosa. And when you ask the patient to open the mouth wide, and if you examine the uvula, the size of the uvula is very small. That's called as bud shape or shrunken uvula, shrunken bud-like uvula. And if you check the tongue movement is impaired. Okay, you will ask the patient to turn around the tongue, move the tongue. No, they will not be able to, because there is an impairment of tongue movement because extensive fibrosis of tongue musculature, and there can be difficulty of mouth opening because of the increase in fibrosis. So all these features which are related to fibrosis are grouped under advanced OSF by Rajendran et al. In this picture, you can see the mouth opening, which is just one finger width, which is about 10 mm. And you can see this is how the blanching looks like. So you can see the extensive blanching in the oral cavity, this patient. And this is also another picture showing extensive blanching. And if you actually palpate these patients, you will be able to visualize or palpate extensive fibrous bands. These are the blanching of the floor of the mouth. Pick another picture of limited mouth opening. You can see the shrunken uvula, and also you can see how much of blanching has happened on the palate. Now, once you have ruled out with clinical feature that is OSMF, you need to confirm with histopathology. So you can do a punch biopsy, or a biopsy is taken and examined under the microscope. When you examine under the microscope, you will be able to see marked atrophy, which is a reduction in the thickness of the epithelium. And just below the epithelium, you will have these juxtaepithelial inflammatory reactions. And also you will be able to see extensive hyalinization, and you will be able to appreciate abundant fibrosis in the connective tissue, and there will be degeneration of muscle. So these are the features of OSMF. Based upon the features of the histopathological features, Pinborg et al. Grouped OSM patient into 4 stages: very early stage, moderately advanced stage, and advanced stage. Very early stage, moderately advanced stage, and advanced stage. So you will have to draw the epithelial cells with about the thickness of the epithelial cells should be less, because it's an atrophic epithelium when you draw, and you can also put hyperkeratosis. And just below the epithelium, you will be showing extensive juxtaepithelial hyalinization, just shaded with pink, and you will show a lot of collagen fibers. And mind it, when you draw the blood vessels, you will not show round, bulky blood vessels. You will show compressed blood vessels like this, and you will also show muscle degeneration like this. This is again an histopathological image where you can see atrophic epithelium, flat retiprosis, and extensive fibrosis and muscle degeneration. And this is the parakeratin layer. Okay, so how do you treat these patients? So reduction or even elimination of the habit of alkanet chewing, at least in the early stage of OSMF, could probably slow the progress of the disease. So ask them to quit the habit. And you have to administer a lot of vitamin B complex and iron for the patient. And you can give physiotherapy with mouth opening exercises, heat therapy. All these will help to cope up. And a specific management, if you look into the mild cases, if you see, you can just give intralesional injection of corticosteroids, because the transforming growth factor beta, which is responsible for both increased collagen production and decreased collagen degradation, which is a inflammatory mediator, which is coming because of the juxtaepithelial inflammatory reaction. Now, if you're going to give corticosteroids, there is going to be reduction in the inflammatory reaction. So likewise, there is a reduction in the transforming growth factor beta, which actually reduces the symptom to much extent. For moderate to severe cases, you have to go for surgical splitting of the fibrous band, or you can go for an intralesional injection of interferon gamma. However, the malignant transformation rate of OSMF is 7 to 13%. Okay, so hope you all understood on OSMF, and we'll meet you again with another topic. Thank you.